I'm Dr. Matthew Davids from the Dana-Farber Cancer Institute and Harvard Medical School in Boston. So going back several years, some of the first patients treated with CAR T were patients with CLL, and there were some very promising early responses. And it's taken a while now to develop CAR T in CLL, but there are a couple of different products that have been in development, and one of them has been this Brexucab product. And at this year's ASH meeting, I'm presenting on the results of the ZUMA-8 study for the first time, looking at Brexucab in patients with relapsed refractory CLL. So there were multiple different cohorts in the ZUMA-8 study, including some cohorts of kind of all-comer patients treated at different dose levels of cells. And then there were also cohorts looking at patients with low tumor burden CLL, and patients also who had been treated with ibrutinib kind of close to the time of CAR T infusion. And there were some differences observed actually, particularly around the responses of these patients. So in the total group of 15 patients, 7 patients did achieve response. But the response rate seemed to be highest in the patients who had low tumor burden. In that cohort, all 3 of the patients responded to CAR T cell therapy. We know in CLL that patients can have exhaustion of T cells, and that it may correlate with the disease burden. And so our hypothesis was that the patients who had the lower disease burden had less T cell immune suppression, and that might have enhanced the activity of the CAR T cells in that group. There were no significant differences observed in terms of the toxicity patterns across the groups. The rates of cytokine release syndrome and neurologic events were relatively high in the range of about 75 to 80% in terms of all grade events. But fortunately, the rates of grade 3 or higher CRS or neurologic events were quite low in all the cohorts. I think that we're increasingly facing an issue in CLL where we have patients that are refractory to our 2 best mechanisms of action, BTK inhibitors and venetoclax, and we had some patients like that on this study. And I think it's going to be important to develop new therapies for these so-called double refractory patients. And we do see evidence in this study that CAR T cell therapy can be an option to consider in these patients. Obviously this is a small data set with 15 patients, so larger numbers would be needed to confirm the initial responses observed. So because the expansion of the CAR T cells on this study was pretty suboptimal across most of the cohorts, unfortunately it looks like Brexucab is actually not going to be developed further in CLL specifically. So fortunately there are other CAR T cell products still in development for CLL. So I think our study does serve as a good proof of principle that you can see responses in heavily pretreated patients, that tumor burden can correlate with response, specifically that lower tumor burden may enhance response. So I think these principles can hopefully be applied to other CAR T cell products that will be developed further in CLL. So I think the next steps really are to take CAR T cells into the phase 3 registrational setting. I think we have enough supportive data from this study and others of other CAR T cell products to know that there are likely benefits, but we need to figure out how that compares to the other available options for these patients. And so I think a phase 3 registrational study hopefully would lead to an FDA approval of a CAR T cell product in CLL, which I think would be a very valuable addition to our armamentarium of therapies. So there's a lot going on right now in CLL research. I think that for most patients, combinations of novel agents that they're given in a time-limited fashion are going to be highly beneficial. And I think trying to sort out what's the optimal combination partner for venetoclax is a key question in the field. And then what to do when patients have recurrence of disease after that initial time-limited therapy. How beneficial is retreatment? And then also down the line, if patients do develop more significant complications like Richter's transformation, how do we treat those patients more effectively? Because that remains a major unmet need in this field.